This patient has undergone cataract extraction with implantation of a trifocal panoptic intraocular lens 3 months ago and was referred with a decentered and tilted intraocular lens. And as we can see here in this left eye, the superior edge of the optic is tilted anteriorly, and in fact it's captured by the anterior capsule. And if we look at the infranasal haptic there, it is almost touching, if not touching, the optic. So it's crimped, and the optic itself is decentered a bit inferiorly. So we've got some issues here, and our hope is that we're able to visco-dissect the intraocular lens free and center it. Now, our task is made possibly more difficult by the existence of a small but open central YAG laser posterior capsulotomy. And the patient has 3 diopters of astigmatism because of the lens tilt. It's not keratometric, and also has poor near vision, and that's likely related to the fact that the central diffractive rings that provide near vision, only one of them is fully visible. You can see the central one. The second ring disappears beneath the inferior opaque anterior capsule. So we may have our work cut out for ourselves, and we might have to resort to IOL exchange. So we have an implant ready should we be unable to satisfactorily recenter and keep this lens well fixated. As the procedure begins, I'm making a side port entry here at around 4:30 o'clock, and I have an opening here, a side port opening supratemporal, so I'm filling the anterior chamber with OVD here, and I can get underneath the capsule here and inject OVD, and it's dissecting around nicely, separating the capsule and fortuitously not headed toward the posterior capsulotomy opening. So let me just continue that and go around in that direction. And yep, we can even rotate the intraocular lens already. So without enlarging that posterior capsule opening, we've accomplished visco-dissection. And now rotate it to uncrimp that haptic a bit and keep the IOL centered. And let me just test to make sure where the best centration is. Looks like it's right around there. So all we've got to do now is irrigate out this OVD and seal these incisions. And I'm going to say that we were a bit on the fortunate side here to be able to accomplish visco-dissection in an eye with an open posterior capsule. A lot of times it just doesn't happen like that. But now we've got this lens well centered, and we have, as you can see, multiple central rings are now exposed. So hopefully that'll take care of the near vision issue. Now this YAG laser capsulotomy may need to be enlarged, if only because the edges of that capsulotomy are fairly likely to cause nocturnal glare issues because of diffraction of light rays as they hit the edges of that capsule, but that can be easily done down the road here. And I can tell you that postoperatively this patient did extremely well, had no distance or near vision problems, and we're waiting to see what happens with any nocturnal glare or halo as to whether or not to enlarge that posterior capsulotomy.